Okay. Welcome, good morning, good afternoon, good evening everyone. Nasaan man po kayo, parte ng mundo. Maraming salamat po and welcome to the 68th installment of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. We are glad that you're able to join us today and that you continue to spread the word about our credible online community as we bring you more timely and informative topics in our COVID-19 learning journey together. So as the cases of COVID-19 surge in the Philippines, we pause to take a look at what is happening around the globe. Are the cases increasing as well in other places? Ano po bang measures are being put in place to curb what is now the dominant variant in many countries? What are the interventions that show promise in controlling the Delta variant? So if you want the answers to these questions from our credible sources and really our excellent lineup of speakers, then you are in the right place. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our Friday lunch date. And I always look forward to Fridays because I get to share hosting duties, most especially with my partner and a beloved mentor and dear friend, also a public health communications expert and our adjunct faculty at the National Telehealth Center, Dr. Susie Pineda Mercado. Dr. Susie?
Hello, Raymond. Good afternoon and good day, everyone watching from all over the Philippines and all over the world. We are all very concerned about the Delta variant. I think we're going to hear today how everywhere we are seeing surges, and we want to know more about what others are doing so that we can learn and be better prepared. So I think we are looking forward to a very exciting afternoon today, Raymond. And I just want to thank everyone for being here, because if it were not for you, we would not be here doing, Raymond, it's the 68th. Is it the 68th webinar?
That's true. That's true.
It's the 68th webinar, and I think our 4th international virtual conference. So occasionally what we do is we invite experts and some of our colleagues from different parts of the world so that all our frontliners in the Philippines also get a sense of what's happening in other places. But for today, Raymond, I was just looking at some of the data about our frontliners who are also working in other countries, and our speakers are going to touch a bit on what's it like, what's happening in terms of the Delta variant and what's it like for the health workers. I was just checking, Raymond. No, we have 150,000 nurses in the United States. We have 18,500 in the United Kingdom, 30,000 in the UAE, and all over the world, we have so many nurses, so many doctors, so many health professionals who are at the front line for COVID for the world. And so I think today it's just fitting that for our person on the street, TVUP is going to get some messages from some thoughts and some views from some of our overseas nurses who are working in different countries. So TVUP, over to you.
About Delta variant, kasi talaga explosive siya no, kumpara dun sa ibang variants na encounter na natin before. Sa Philippines, as in talagang grabe, di ba? Pero we were quite surprised dito sa Germany pagdating namin. Hindi na hindi na namin kailangang mag-face mask sa labas ng bahay. So, pinagpa-face mask lang kami sa loob ng mga closed spaces like cars, hotels.
So, nung nag-start nung March 2020 last year, so, ayun, very, very scary for everyone. Like, hindi natin alam yung nangyayari. Pero ngayon, we're lucky here. Nag-start na kami magkaroon ng vaccine. And which is good here sa UK, free yung vaccination.
The situation, it's nothing really much changed compared to when it was started.
COVID pa din, pero hindi namin ma-confirm kung meron ba talaga kaming Delta variant. Alam lang namin na nagkakaroon pa rin kami ng the odd ones na COVID positive.
Yes, at work, it's a must. You have to wear a mask. Facials, not really unless you're taking care of COVID patients. It's not required, but it's highly recommended. But some of them, go to different places. They're not even wearing anything. They're just, no mask, no face shields.
Dito lang, sobrang ine-emphasize nila yung hand washing, hygiene, tsaka talagang nag-social distancing sila. Pag sinabing social distancing, as in, hindi lang nga isang metro, parang 6 feet nga yung pagitan.
Wala akong masyadong opinion kasi like I haven't really looked after someone na may Delta variant. I've looked after mga COVID patients, pero like I said, hindi nga siya confirmed talaga kung Delta variant. Pero it's quite worrying kasi dahil since open na ang UK for traveling, I think Delta variant mas common siya around Asia side. Like once na more Asian people coming sa UK, it's worrying na baka tumaas or baka mas manotice na namin yung Delta variant.
Sabi nga nung infection control officer, nung nakausap namin, as long as you're vaccinated, huwag daw masyadong mag-worry kasi vaccinated naman daw na kami. Almost lahat vaccinated na. And actually, dito sa hospital ngayon, they're about to have their 3rd dose na. So, ganun silang kabilis. And even yung mga testing nila, sobrang accessible, free lahat yon.
For me, like especially sa mga talagang hesitant pa rin o sa mga worried sa mga possible long-term effects, I feel like it's still better to have that. Hindi naman nila ito ilalabas kung sa tingin nila magkakaroon ng long-term effect.
Sa mga hindi pa nakakapagpabakuna, magpabakuna kayo. Huwag na kayong mamili ng brand kasi ang importante ngayon is bakunado tayong lahat. And hopefully, gumanda na yung sitwasyon natin yung sa Pilipinas kasi para makabalik na tayong lahat sa normal.
Everyone get vaccinated and everything will be as close to normal as possible.
Okay, thank you so much, TVUP. Really inspiring, and it's a lot of effort for us to be able to reach out to all of our kababayans po across the pond, all over the world, and we're really thankful for their time and for their support as part of this webinar series. And it's good to know that what is really happening on the ground, we have a sense and we're able to listen to our healthcare workers. For our webinar, we are able to accommodate up to 3,000 participants. So please join us in the Zoom. We are numbering now, I think, nearly 1,200. Isa na, oh yun, okay, we crossed the 1,200 mark just now. So we are hopeful that a whole lot of your colleagues, families, friends, those who are joining in maybe later, sana maka-join na po sila a little bit earlier. For those who are watching us in the YouTube channel of TVUP as well as the Facebook pages of Stop COVID Deaths, University of the Philippines, and also TVUP, maraming salamat po, and I hope you'll be able to watch the playback for this webinar po. But we really encourage everyone to join us in the Zoom so that you get the full experience of our online community. And for those who are asking, the certificates of attendance po, no? They will be sent out, and that's something that I have mentioned before. Hindi po siya bulto-bulto kasi we have been receiving emails po and messages. Bakit po may iba po nakakatanggap at hindi pa po yung iba? So those really, that it's being sent out in batches and given to those who have watched at least 50% of the webinar duration po. So we're hoping that we'd be able to send it out as quickly as possible. And for those who have not received certificates for the previous 67 webinars, please let us know at stopcoviddeaths@up.edu.ph. Okay, that's a little bit of a segue into what is happening po. Did you want to say anything, Dr. Susie, before we open the webinar?
Well, yeah, I think you're going to give a quick overview of the webinar and our speakers. So just go ahead, Raymond. Go ahead.
Thank you, Dr. Susie. So for our webinar for today, which we will be tackling, it's considered the dominant variant in many parts of the world, and I think by the end of August, either August 30th or August 31st, there was a recognition already of the community transmission of the more contagious Delta variant in the Philippines, and also the essentially confirmation of its dominance as the dominant variant po, no? The Delta variant here in the Philippines. So, the numbers based on the recent biosurveillance report released on August 27, it shows nearly 69% of all of the samples reviewed were confirmed to be caused by the Delta variant. So the total stands right now, at least for the Philippines, 1,789 Delta cases, or 14.12% of the variant cases in the country. So we invited a few of the leading experts in the different countries, Japan, we have one from Thailand, from Taiwan, obviously from the Philippines also, and from the United States, to talk about their current situation, what is being done, how it is in all of their locations, and is this something of that will benefit from a shared approach, really learning from everyone's strategies and best practices on the ground. So to introduce and get our webinar rolling, I'll turn the floor over to Dr. Susie Mercado.
Thank you very much, Raymond, for that introduction. Okay, so I think we want to go straight to the meat. And we have with us an infectious disease expert, one of the leading infectious disease experts, who is he's a member of the UP Medical Alumni Society in America. You have met him before, and he's one of your favorites, one of our favorites, who talked to us initially about the Delta variant in the beginning, and has been giving us updates on what's happening in the United States. And we are just very pleased to have our first speaker all the way from California, Dr. Franco Felizarta. Dr. Franco, welcome to the webinar.
Thank you for the kind introduction, Dr. Susie. So, good afternoon to all of you. Magandang hapon po sa inyo lahat. This will be my third talk. So sana po wag ho kayong magsawa sa mukha ko. So I will have about 20 slides. So hopefully we can finish this in 10 minutes. I have about 10 minutes, right? So let me share my screen now.
So Franco, while you're doing that, how is your family in Quezon? Is it Quezon where your family is?
Yeah, they're actually in Taguig City. So originally from Mauban, Quezon. So
how are they doing? Kamusta naman sila?
All they're doing fine. All vaccinated. So at least I'm more comfortable. A few with Sinovac, a few with AC. So we'll have a natural experiment between the two. Just joking.
Which we'd like to hear about at some point. Go ahead with your presentation, Dr. Franco. Go ahead.
So, see, you can see the you can see
now
clearly.
you're in slide. Yeah, you're in slide. Okay.
Thank you. So this is just an update of my previous talk on the Delta variant, and these are my disclosures. Obviously, lots of pharma here. Also an NIH site for outpatient COVID treatment that's active too, and I'm a minor contributor for the Octa research team. So before I start, let me just summarize my first talk on the Delta variant and just the highlights. I mentioned that the basic reproduction number of the Delta variant is 5 to 8. There's actually some studies showing it's probably up to 9.5. So really the herd immunity is approaching 80 to 90%. I also mentioned in my previous talk that all the vaccines are effective in protecting against severe disease that includes hospitalizations and deaths, at least 85%. And the breakthrough infections, of course, will not be uncommon. And if you get a breakthrough infection, it will tend to be milder, and there will be decreased secondary transmission. There's some data showing there's actually a decreased mutation rate. So let's start with the variants of concern. Of course, we have Alpha, which is first detected in the United Kingdom, Beta from South Africa, Gamma from Brazil, and of course, Delta. We're gonna concentrate on Delta, which was first detected in India. I mentioned before that there was no Gamma in Africa, but now obviously there's South Africa, Nigeria, and Sudan with Gamma. So in the United States, when I did my talk in July 16, a majority already still already Delta variants, but now, as you can see, it's more than 99%. More than 99% are Delta, overwhelming. This one is from my previous talk in on July 16, and this is showing the epidemic curves of the new cases and deaths for the United States. As you can see, there's a slight increase in the cases at that time, and there's stabilization in the deaths. And this is despite the mobility increasing to baseline. And I made a forecast during that time. I made a prediction that it will be similar to the epidemic curves of the United Kingdom, where the cases increased. There's a significant increase, but the death curve is quite flat. We call this decoupling of the cases and deaths. And this is despite the increase in mobility to baseline. There's actually no mask. They actually stopped the mask mandates, at least in the United States. So what happened? Anong nangyari? So obviously I was wrong with my prediction. United Kingdom, of course, it peaked, and then of course there's a decrease in cases here. There's some stabilization of the hospital admissions. For deaths, it's quite flat. It's actually still increasing, but it's quite flat compared to the cases. But the United States, look at this, increase in cases, increase in hospital admissions, and the deaths are still increasing. So what is the explanation for this difference? And it's probably the vaccination rate. As you can see here, there's still a lot of cases, a lot of areas in the United States where the unvaccinated population is more than 10%, And in United Kingdom, most of the unvaccinated population is less than 5%. So the difference is really about 10%. I thought it will not be a big deal, but obviously the herd immunity probably really approaches 90%, and that's why there's a big difference between United States and United Kingdom. This one is the Delta variant nationwide transmission. As you can see here, the initial high-level transmission happened in the southeastern United States. And this one is showing you the correlation between the 7-day case rate per 100,000 and the percent of state population vaccination. So if, for example, Louisiana, Arkansas, Missouri, and Alabama, they all have low vaccination rate, only about 35%. They have the highest case rate per 100,000. This is Vermont, approaching 70% vaccination rate, and they have the lowest case rate per 100,000. The only outlier here really is Florida. They have a decent vaccination rate of 50%. The population is half of the population vaccinated, but they have a very high case rate per 100,000. This one is just from the Kaiser Family Foundation, Kaiser Family Foundation, showing the difference in vaccination by race and ethnicity. For African Americans, 40%, Hispanic non-white, Hispanic white is 45%, white non-Hispanic is 50%, and for Asian it's pretty high, 67%. 2/3 of the Asian population is vaccinated. And I don't have any data for Filipino Americans, but I'm pretty sure it's near the 2/3, 67%. And for the elderly, I'm pretty sure it's more than 90% of the subpopulation is vaccinated. So I'm confident that the Filipino Americans will be protected, at least against severe disease, severe COVID disease. Now, this one is from the McKinsey's healthcare system analysis from several sources, and one of them, of course, is CDC. This is just showing you the hospitalization and their death epidemic curves for the unvaccinated population, which is the blue dotted line, and the vaccinated population, which is the blue solid line. The black solid line, of course, is the entire population, will be in between the two. And as you can see, for the unvaccinated population, there's a tremendous increase in number of cases, even higher than that of the winter surge. And for deaths, it's quite significant. But for the vaccinated population is quite flat. This lower threshold is the influenza rate, hospitalization and death rate, and the upper threshold is the peak rate. And as you can see, hopefully during the winter season, it will not reach this threshold for the peak influenza rate. This is actually our goal for COVID-19, is just to be at least similar to the influenza. We don't have any immunity yet against influenza, but at least we're controlling it with regular vaccination. However, the problem is we underestimated the number of unvaccinated individuals. This one is from Chile, which use Sinovac. And as you can see, there's increase in cases, but in terms of number of deaths, it's actually quite relatively flat. So there's still decoupling here, and this is despite increase in the baseline mobility. This is from the Philippines. This is from my previous talk, showing there's a decrease in cases and the deaths are stable. Obviously, there's increase in mobility. At the time, the Delta variant still starting, and obviously, I made a comment that it's unstoppable. The Delta variant is unstoppable, and as you can see, that there's a tremendous increase in number of cases in the Philippines, although the increase in deaths is not proportional. So it looks like there's some decoupling between the case and the deaths, and this might be secondary to the high vaccination rate of the elderly in the National Capital Region. The problem is if it spreads outside of the National Capital Region, because the vaccination rate for the elderly outside of NCR is much lower, and of course there's also increase in mobility in the Philippines. So that's a concern. This is, of course, from India. India did not have any decoupling. Okay? No decoupling with cases and deaths. About 500,000 reported deaths. The estimated excess deaths, according to a Harvard study, is about 5 million. So obviously the cases decreased because of the decrease in mobility, but it's increasing again. So we don't know if a significant proportion of the population is still not infected, they will have a next wave. Now, what is the reasoning behind the increased transmissibility of Delta? And this is from a study from Singapore showing that the viral load of the Delta variant is much higher compared to the other variants. This is the viral load. It depends on the city value. The lower the city value, the higher the viral load. The higher the city value, the lower viral load. So, for example, if it's 4 to 5, that will be the threshold. So lower than that will be considered undetectable. And this one is also from Singapore, showing a study comparing breakthrough infections from vaccinated individuals and infection from unvaccinated individuals. As you can see, in the first 5 days, the viral load is high and comparable. But there's a rapid drop in the viral load in breakthrough infections in vaccinated individuals. This might explain the increased protections against severe disease. This one is from a preprint by Shamir, and this one is showing that although the viral load is comparable between unvaccinated and vaccinated healthcare workers, the probability of culture positivity is lower in patients who are vaccinated with breakthrough infections compared to unvaccinated. So there's actually decreased infectiousness compared to unvaccinated individuals. This one is just from multiple sources, just showing that there's decreasing protections against infections, including asymptomatic infections, especially in Israel, versus the Delta variant compared to the Alpha variant. But if you look at the hospitalization or death rate or severe COVID disease, there's actually not much of a decrease. Still 100% in Qatar, 91% Israel, 96 to 100% in England and Canada. So there's lower protection against infection, including asymptomatic infections, but still great protection, efficacy against severe disease, including hospitalizations and deaths. This one is from the Mayo Clinic Health System, showing there might be some difference between Moderna and Pfizer. There's in terms of infections, including asymptomatic infections. But if you look at hospitalization rate, there's really no significant difference between the two. This one is from the MMWR, a study showing that the vaccine effectiveness is decreased comparing the pre-Delta variant predominance and Delta variant predominance from 91 going to 66%. It also shows that there's probably some waning in immunity, 85%, 14 to 119 days after full vaccination, decreasing to 73% with more than 150 days after full vaccination. So there might be some waning in immunity. However, in this study, based on the COVID-19 cohort, although there's an increase in infections, these are the surges, not infections, sorry, hospitalizations. For the vaccinated population, it's quite flat. The hospitalization rate for the vaccinated individuals with breakthrough infection is quite flat. Okay, there's not much difference. And this is the last slide. This is from LA County reported in the MMWR, showing the infection and hospitalization rates from May to July. And this is when the Delta variant became predominant. And as you can see, there's an increase in infection rates. Some is slight increase for vaccinated and partially vaccinated individuals. But for hospitalization rates, although there's increases for unvaccinated, it's quite flat for fully vaccinated and even partially vaccinated individuals. So even partially vaccinated individuals have great protection against severe disease. That should be it. That's all I have. Thank you.
Okay, thank you very much. That's Dr. Franco Felizarta coming to us all the way from California in the United States. And thank you for the excellent presentation, Franco. I think our audience always appreciates your talk. We can really see the effort that goes into preparing these slides. And I think it's really very interesting how things change over time. It was just 2 months ago that you were with us, and things really changed so quickly. And we always say that on this webinar that, whatever it is we're bringing you is to the best of our knowledge based on the science. And Franco, if you can see Franco's slides, they're like July 2021, August 2021, publications that are fresh, very, very fresh. So thanks, Franco. I think we shall talk a little bit more about decoupling. I think that idea, that concept is very important for our audience, for our frontliners. And you can see in the chat box all the appreciation for yung kinakarir mo yung presentation. We really enjoyed it so much. And I think everyone has learned from it. So I'm going to turn over to Raymond now for our next speaker. Raymond, go ahead.
Thank you, Dr. Susie, and thank you for that excellent presentation, really for providing us with the latest updates, Dr. Felizarta, especially since this is your third time and we've already had you discuss the Delta variant at least once before in our previous episode. So we look forward that in your talk and also your insights that you will share during the Q&A session later on. Our next speaker will share with us the Japan experience in handling the Delta variant. He is a professor from the United Nations University International Institute for Global Health and the Kanazawa University. He sent in a video presentation and let's all listen in to Professor Atsuro Tsutsumi. TVUP.
Hello, everyone. My name is Atsuro Tsutsumi from Kanazawa University, Japan. Thank you very much for inviting me this very important initiatives. Thank you very much for this great opportunity. Today, I'd like to talk about the current situation of COVID-19 and the Delta variant in Japan. Let me share the slides first, please. Yes, today's title is the current situation of COVID-19 and the Delta variant in Japan. This is the map of the current situations of I'd like to introduce the current situation of COVID-19 in Japan. This slide shows the map of the first coronavirus state of emergency in Japan. The red is the prefectures under the state of emergency at this moment. As you know, that Tokyo is one of that, and Osaka and Hyogo, Kyoto, the very big city in Japan, are all included and under the state of emergency. Key measures in place in Tokyo is, I'd like to explain later, but the state of emergency is not the city lockdown like other countries do. This is the countermeasures in Tokyo under the state of emergency to decrease the number of infections. The first one, excursions. Tokyo Metropolitan Government, the request to remain in the place for residents to avoid non-essential excursions and refrain from travel between prefectures. The companies are urged to implement remote working policies with a goal of reducing the number of commuters by 70%. In-office employees should finish their work by 8 p.m. and go home directly. 8 p.m. is also still, the rate, but this is the one of the countermeasures in Japan and the state of emergency. And for the bars and the restaurants, bars and restaurants that severe alcohol are asked to close. Those that don't provide alcohol are allowed to operate until 8 p.m. If they don't, they provide alcohol, they can open by 8 p.m. Takeout delivery services can continue as normal. The people are asked to refrain from drinking in groups on the street or in the parks. The large commercial facilities, including department stores, are asked to close by 8 p.m. Areas within these sites that all offer everyday products can remain open as normal, like a supermarket. Theaters and exhibition halls and the movie theaters are asked to close by 9 p.m. The event organizers are asked to limit venue capacity to half of their capacity, or 5,000 people, whichever is smaller. The events must end by 9 p.m. They are asked to urge attendees to not stop anywhere on the way to or from venues. It is something, the contradiction that, the number of COVID-19 is increasing. Now we are under the fifth wave, but we hosted the Olympics. That is very curious, right? And the government intensive antivirus measures. The yellow one is not under the state of emergency, but they are under the intensive antivirus measures. It means that under the intensive measures and the state of emergency declares, governments can ask businesses to shorten operating hours. If a business ignores a request, the governor can issue an order and publish the name of the business. On-site inspections from local officials are also permitted. The request for business closure can only be made under the state of emergency. Well, this is a comparison of the countermeasures between state of emergency and intensive antivirus measures. The prefecture's government can impose fines on businesses that don't cut operating hours or refuse on-site inspections. Intensive measures allowed fines about 200,000 yen, which is the equivalent to $1,800 or so. And that this raised to the 300,000 yen, which is about $2,800 under a state of emergency. Early this August, Aichi Prefecture, which is one of the biggest city in Japan, announced that the 46% of specimens tested from some of the people infected with the COVID-19 had the L452R, C in the Delta variant virus in the week up to the first. The percentage has more than doubled the week by week, from 18% in the previous week to 8% in the week before. The spread of the highly infectious Delta is likely to lead an increase in the amount in the number of the infected people. Looking at the 171 Delta cases confirmed by Aichi prefectures, 70% of them were in their 30s or younger. Those in their 20s accounted for 30%. Those in their 30s, 21%, and those in their teens, 15%. There were no critically ill patients who are on ECMO, and moderately ill patients, such as those with a sign of the pneumonia, accounted for 9%, mild cases 85%, and asymptomatic cases 6%. In Tokyo, it already announced that for almost 46% of the total cases in the week of July 12 to 18th. And as of the 1st of August, Delta type is already considered to account for more than half of the cases. However, according to estimates by the National Institute of Infectious Diseases in Japan, the Delta type accounted for around 70% of all new infections in late July in the Tokyo metropolitan areas and 80% in Okinawa Prefecture. All of these areas experienced a rapid increase in the number of newly infected people, and the latest news announced it reached 90%. The basic infection control measures remain the same for Delta variant. However, more stringent infection control measures are required because it is believed that the virus is more easily transmitted than ever before. Thank you very much.
Thank you very much. That was Professor Atsuro Tsutsumi from Kanazawa University, again, for preparing such an amazing presentation. I know there are many of you, I see a lot of konnichiwa in the chat, right? So I know many of you have family members or friends who are working in Japan, but they are also now into their 5th wave. So very interesting. Unfortunately, Atsuro will not be able to join us for the panel, but we would like to thank him for the time that he spent putting this together. So we're going to our next speaker, and it is my honor and my pleasure to introduce someone I've worked with before. He is an expert in communications, particularly in risk communication. And I met our speaker because he was the communications officer for the World Health Organization China office during the outbreak of SARS. So he comes with a lot of UN experience, but he's currently based in Thailand. He's doing communications work for the United Nations, and he will talk to us about what's happening in Thailand and talk to us a little bit about communicating the risks of this Delta variant. So my pleasure to introduce and to welcome Roy Wadia. Roy, welcome to the webinar.
Thank you so much, Dr. Susie, and hello to everyone. It's a wonderful experience to be with all of you and to have such a huge audience. We try to get 100 or 200 people for our webinars, and that's considered good. And I'm hearing that you've got huge numbers, so I'm really impressed. And I want to know the secret of your success and actually spread the word far and wide. So I am going to take you through a story, and I'm going to show you my slide presentation. Hopefully you'll see it. I hope you can all see the presentation.
Yeah, it's looking good, Roy.
Great. So I'm not a doctor, even though people sometimes call me Doc Roy. I wish I was a doctor, and my mother, I'm sure, wishes the same. But I am a journalist and a storyteller who happened to wander into the world of public health, medicine, science, and research at the World Health Organization after many years at CNN. So I do apologize if my presentation is not technical, but it's more of a story. But hopefully it weaves in quite a bit of the substance of the theme that we are talking about today, which is the Delta variant. So as you know, Thailand is a land of smiles. I've been here for the last almost 7 years. It's a wonderful country with wonderful people. It's really an amazing experience being here, gentle, polite, and yet, of course, not all is as it seems beneath the surface. And with COVID-19, it's really shown the challenges and, of course, the opportunities that we have to make things better. So before we talk about Delta, let's just quickly go back in time. It looks like it's been ages, but it's been less than 2 years when this tiny microscopic creature burst onto the scene. And in the early days, Thailand did extremely well in tracking down the virus. They've got amazing scientists and researchers, including this wonderful lady, and she and her team, they sequenced the virus in the very early stages. And this was the first WHO situation report on 6th February of 2020, with 25 lab confirmed cases, and mostly from Chinese tourists. And you can see the graph, hardly any cases in the early days. There were batches when there were just no cases at all reported. And yet people, of course, sprang into action. They took great precautions, mask wearing with the temple dancers and everyone across society. And then fast forward to 2nd of September, still a very small number. As you see, only 3,425 confirmed cases by that time, with 58 deaths. Of course, I wouldn't say only, because one death is one death too many, but compared to all the Thailand, a really fantastic caseload, if you will, in that sense. 93 hospitalized, and most of the people recovered quite well. And you also see, if you go straight down the year 2020, as the small numbers keep adding up, the actual daily caseload is very low. So from a sort of peak early on in the first wave, it sort of dwindles to practically zero. And the World Health Organization commends Thailand for this amazing public health response. That's the former WHO representative, Daniel Kertes, with the Thai health minister. And the frontline workers in Thailand, they've got a 1 million strong army of volunteers in the towns, villages. There is Bangkok as the big city, and then there's the rest of the country. Chiang Mai is the second city, but it's really a village compared to Bangkok. And then you've got countryside, of course. And these 1 million workers, volunteers, they were the ones who did the contact tracing. They were the eyes and ears of the health authorities. And in large part, it is thanks to them that they were able to pretty much stamp out COVID in the first year or so. So, of course, the World Health Organization praises Thailand. There was a film made on this amazing success. And they also did a very good job in communicating the facts from the World Health Organization. Lots of programs on TV, radio, daily press conferences in both English and Thai. So they were also addressing the significant expat constituency here and the country as a whole. And there was a review done by the World Health Organization of how Thailand was one of the early successes, one of the few successes in COVID-19. But at the same time, there was political unrest. And you may have heard about the mass protests that started last year. And these continued for quite a long time, all the way through the second phase of COVID-19, and they have recently re-emerged as well. At the same time, the economic devastation, huge, it can't be underestimated and not talked about as much because in this country, people really sweep their challenges under the carpet. They don't share, they don't emote, they are very circumspect. But there was no denying that the devastation has been huge, and the numbers of people taking their lives quietly, very understated, has really shot up. And there's been a fair amount of coverage on this angst and this devastation. And so the economy has suffered, and you can't separate the economic consequences of the pandemic from the health consequences. They go hand in hand. And this has become a political issue as well. Thailand actually has been one of the world's most unequal countries. You might find that hard to believe, but in terms of the GDP distribution, the equities on so many indicators, it is definitely one of the world's most unequal societies. And the mental health aspects were huge as well. And so at the UN, we collectively started with Facebook and with a very strong mental health agency, a Facebook-based campaign called Unknown Together, which was aimed at people suffering across the socioeconomic spectrum, because many people use Facebook and it really cuts across rich, middle income, poor, etc. And it was in the Thai language. And it did a lot to break the stigma of having mental health, psychosocial issues. And it really brought the dialogue up. Of course, we couldn't reach the entire country, but it was a significant audience impact. At first, Thailand did not join WHO's COVAX consortium. It said that as a middle-income country, it would not be able to buy vaccines at a good price. So it preferred to do its own vaccine procurement through its own vaccine company based over here. And it came under criticism for that because, as we know, when Delta started, the situation changed significantly. And this fed into the political unrest and the angst. And suddenly, after being a success for a year, Thailand was called, in many ways, if not a failure, at least a cautionary tale, because the vaccine rollout didn't happen as planned. And there was a shortage. And even countries like Bhutan shipped small amounts of vaccines to Thailand as a goodwill gesture. So it's truly ironic that a huge economic powerhouse like Thailand actually acquired vaccines from wherever they could get them. There was a scramble. And then, of course, the vaccination rates, not surprisingly, were low. They didn't reach the elderly in a significant way in the early phase of the vaccine rollout, which started only in June. So some say that Thailand really squandered 6 months of lead time when, if they'd had vaccines earlier, they could have actually prevented what happened. And of course, once Delta burst onto the scene, it quickly overtook all the other variants that were out there. And now from 78% in early August, it's pretty much the only strain that's truly prevalent in a significant way. And so you've got lots of coverage. You've seen that Delta is impacting younger people. I've had friends whose kids have been COVID-19 positive. They've been largely asymptomatic, but their parents have actually fallen ill significantly. And I've had friends who've been in the ICU, and it's been quite scary because they, in a way, acquired it through a conduit that they hadn't anticipated, given the history of COVID-19 earlier. And so this was the scene not long ago where the Bangkok hospitals were really overwhelmed, and they were scrambling to put up new hospital beds and stadiums, trains, schools, etc., etc. But now, because the volunteer system is still very strong in the countryside, they've been stepping up and they've been really supporting people who are staying at home with COVID-19. They've increased vaccination, new stock has been created. They are importing different kinds of vaccines. And so, from a Sinovac and AstraZeneca base, they're now actually importing Pfizer, Moderna. Of course, it will take time for it to come up to speed. There's also been very confusing communication sometimes about mixing the jabs and who is eligible and when and how, and there have been many applications online that you've got to sign up to. So it's been a bit of a scramble getting the process consolidated, but it's starting to happen. Of course, all of this has meant that Thailand's rankings in the resilience indexes has slipped. And, once again, there have been studies done, there's been research done on why from the best recovering country, Thailand is now amongst the worst, but hopefully that is starting to change. So one study said that there was complacency. It did so well that it became complacent. Also, the public health experts were in charge of the vaccine policy, but they didn't talk to the economic wing of the country. And of course, economists have been pushing vaccines as the only way out. Also, there was mismanagement of the vaccine policy, and were all the options carefully considered? Maybe not. And then the failure on the public communication front, I would say, has been more recent perhaps. In the first year, it was actually fantastic. So this is just one study, but it really captures many of the challenges that we saw. There's also been a political dimension. It's now illegal to, in a way, criticize certain aspects of the government response to COVID-19. But things are starting to really improve. Thailand has joined COVAX. It will now be eligible to tap into it. It is stepping up the vaccine numbers, both homegrown and the imported ones. It is jabbing more people now. So nearly 90% now, probably nearly 100% of the capital has at least had one shot. And there are 120 million shots planned for 2022, probably even more as the things change. So this is a lot of social media coverage on the self-testing kits that are now rolled out across the country. The numbers are high, but they are coming down. A few days ago, the daily caseload was reported to be in the mid to high 20,000s. Now it's coming down to 14, 13. So we are hopefully seeing a sort of improvement of the situation. Starting from this week, the lockdowns have been eased. And so we may go back to semi-normal again. But let's not be complacent. There are still warnings that given the low vaccination rate at this time, opening up too fast might actually be counterproductive. As we ramp up the shots, we have to also be mindful that yet every day, because of Delta, we are seeing a significant death numbers. So, from having hardly anyone dying all of 2020 every day now, 200, 300 deaths. So we're not out of the woods yet. There is still unrest going on. COVID-19 angst is actually feeding into that. And this is likely to continue for a while. The government continues to be targeted for this. But let's be optimistic. Let's do our best. We know that Delta will continue to circulate. New variants are around the corner. We don't know how that's going to unfold. The country is starting to open up again. You may have heard of the Phuket sandbox, where people can go and quarantine in a more open sort of context, and the country will have enough vaccines most likely in the year ahead. So once again, this is a snapshot of how Delta has been handled, but in the wider socio-political context. And I really hope, speaking personally, that this beautiful country is able to round this challenge and, truly look forward to a much better 2022. Thank you.
Thank you very much. That's Roy Wadia reporting to us. Like it's like a CNN thing. Presenting to us from Thailand, from Bangkok. And thank you, Roy. I think again, brilliant presentation. The audience really appreciates the time and the effort that went into following all the news, giving us the timeline for Thailand, and also showing us how there was an up and then a down for Thailand, and now it's going up again in terms of the government response. But truly, I could see that you really researched the topic a lot, and that is very much appreciated. So thank you very much, Roy, for joining us, and we're looking forward to hearing more on your insights when we have the panel discussion. So Raymond is now going to introduce our next speaker. Raymond, over to you.
Thank you so much, Roy, for sharing with us the lessons and recommendations in communicating the Delta variant, as well as a little bit about the mental health issues as a result of the pandemic. We really appreciate it, and we look forward to your insights during the Q&A later in the program. And our final speaker, I believe he is our final speaker. Second to the last speaker. I'm sorry. We haven't had Philippines. Our second to the last speaker joins us from Taiwan. He is the Medical Deputy Superintendent at the Kaohsiung Municipal Minsheng Hospital, as well as Assistant Professor at Kaohsiung Medical University. Please welcome Consultant for COVID-19 Pandemic of the Kaohsiung City Government, Dr. Chun-Yu Lin. Dr. Lin, welcome to the webinar.
Thank you very much for your kindly invitation. Can you see my...
Not yet, Dr. Lin. Well, we're waiting
okay.
for it to show up on the screen.
Okay.
Okay, there we go. Go ahead, sir. Looks good. Dr. Lin, go ahead.
Thank you very much. Yes, it's my great honor to join this very excellent webinar and to share the Taiwanese experience with you. It's a very different situation in Taiwan. I will let you know how the Delta variant goes in Taiwan. Today, I will talk about the wave, the surge of COVID-19 in Taiwan. And we are a very small island, a small country, you know. So no matter the southern Taiwan, like Kaohsiung, or the northern Taiwan, like Taipei City, we are very close to each other. So the whole pandemic in Taiwan, almost cases were very close to each other, and the whole policy over through the Taiwan was similar, no matter in different cities. So I will let you know the whole policy and the vaccination program. So this is the daily new confirmed cases in Taiwan. The y-axis is the number of per million cases, per million people. So you can find we have no big pandemic in Taiwan in 2020, but only in this May, after 15th of May, there is an outbreak in Taiwan with our domestic cases. And with this wave, you can see here, it comes from 15th of May, and it reached the peak just 1 week later. I mean, you can find the peak of cases in Taiwan is on the day of 22nd of May. And within this outbreak, there are 99% were infected by the Alpha variant rather than Delta variant. We only have less than 30 cases were infected with the Delta variant in Taiwan. So it's a very special situation here. So you can find there is a very low case number in Taiwan. Nowadays, the total confirmed case of COVID-19 is only 16,000 in Taiwan. It's very rare. But we have another problem is that within those confirmed cases, we have a very high mortality rate. You can find we have almost 5.2% case mortality rate versus the 2.1 global data. So this will be another problem for Taiwanese government, also the medical staffs. I will explain more later. This is the vaccination doses we gave in Taiwan. And you can see we start to make more vaccination shoot injection from 15th of June. So it's almost 1 month later than the big wave in Taiwan. And now you can see we have only gave 10 million shots to our people. But in Philippines, I think you gave more than 30 million. So it's a big achievement for you. And we have to catch up. So we start to get the vaccine injection much late than you have done in the early 2021. So with the pandemic case, the curve in Taiwan, you can find a very special situation. And we did it. I mean, we flattened this wave very quick. 1 week after the big surge, we start to, the cases numbers start to decline. And you know, we start to get much more vaccine from mid of June. So the wave, it start to be flattened. It's not caused by the vaccination program. But the NPI, it's named the non-pharmaceutical intervention get the curve to be flattened. So it's a special situation, and the NPI means surgical mask. I mean the masking. We ask everyone to wear that when they were going out from their home, their apartment, and we ask everyone to keep so-called social distancing like that. And we did not give so much vaccine during the first stage of the curve in May. So only the non-pharmaceutical intervention gave us the chance to flatten down the curve. And we have only a small outbreak due to Delta variant in Taiwan. It happened in late June, almost 1.5 months after the outbreak in May. And this was caused by the returning travelers from Peru. There are 2 returning travelers bring the Delta variant into Taiwan, and they were quarantined in their home within a small village. So it's not in a big city in Taiwan. So they were only 13 cases confirmed to be infected by the Delta variant. And this is the only outbreak domestically in Taiwan so far. We do a lot of contact tracing and to quarantine all those contact person to make sure they were not be infected by the Delta variant and avoid to transmit those virus to the others. And we do a lot of examination to do the PCR, to do the antigen test, to cut down the transmission route of Delta variant. And we contain those infected cases very seriously. Within that small village, there is a semi-lockdown there. But in the other area of Taiwan, it's almost the same measurement. We didn't put on even more restriction during that Delta variant outbreak. So it's a very special situation in Taiwan. As you know, we are an island country, so we can carry out very extremely strict border control policy. I mean, now if you are citizens or if you have the visa, then the others cannot border to Taiwan. They cannot be allowed to enter Taiwan during this stage. So it's very strict. And everyone, no matter you are citizens or other people with visa, when you are boarding to Taiwan, you have to be quarantined within a hotel or in camp for 2 weeks. And in the beginning of this quarantine phase, you have to be examined with the PCR. And on the last day of the quarantines, you have to be tested again with the PCR assay. So it's a very strict border control policy to avoid the virus to come into Taiwan. So this helps us to maintain a very low case number, but we have high death number. So high cases mortality rate, how it goes. I think first is the short responding time in May. So we did not do it very well. We have not enough medical devices, medications during the May in the early stage of this epidemic. And also the human resources were relatively limited during that stage. So it's the first reason we have so many mortality cases. And the other one, I think probably is most important, is there are some undiscovered cases in Taiwan. So we estimated that the true cases in Taiwan is about 200,000 cases like that, but it's only 1% of the total population. So it's not very common here. And the vaccination program in Taiwan, we have 3 different kinds of vaccine named as AstraZeneca, Moderna, and the Medicine. The Medicine is a Taiwanese company, and here is the total doses we gave. Most of them were AZ, and 1/3 are Moderna, and about 5% were Medicine. And from September, we will have Pfizer BNT vaccine in our vaccination program. And only 46% people were injected with the first shot. Most of them were aged patients, but only less than 5% people were given with second shot. So look into the future, we have some problem, you know. It's a very special situation here, but the concept of our public, they cannot, they have to be convinced that we have tried to live together with the virus instead of to be alone to the whole world, you know. So we have very rare naturally infected cases. As I mentioned, it's only less than 1%. It's very special situation so far. Even we increase the vaccination rate. But how about the herd immunity, you know? Because most of cases in Taiwan, they were infected by Alpha variant. So we didn't know how those infected cases could they play good to defend with the Delta variant. And the other problem, which could be more serious, is that most people in Taiwan, they get the antibody from the vaccination. But how long could this vaccinated patient, the antibody could be lasted? How strong the immunity to the different variants of SARS-CoV-2. So this will be a big problem for all of Taiwanese people. And the other things is that I also mentioned about the mental health versus very strict non-pharmaceutical intervention policy. It's lasted for 1.5 years so far. It's very strict. So how long our people can be tolerated to this? And the other things I think is also very important is that we have to prepare or try to find some more antiviral drugs and some good strategy to treat our patients. Otherwise, we will have so high cases mortality rates. But all these things should be communicate with our general population to let people know. So it's a very special situation here in Taiwan, but we have so many different problems to be resolved so far. So this is the Taiwanese situation, and I would like to share with you and get a lot of feedback from all of you. Thank you very much.
Okay, thank you so much, Dr. Lin. You will see on the chat that there are a lot of people are commending Taiwan for the measures that you have instituted. And we hope to learn more from your insights during the Q&A session later on. And it's something to be impressed about, especially during the early part of the pandemic, when you really were leveraging different tactics, technology from the policy side, cross-border control. That's something that all the other countries in the region were trying to emulate. So we look forward to your sharing later on during the Q&A. Dr. Susie will introduce our next and final speaker for today.
Thank you very much, Raymond. Last but not least, we're going to hear from the Philippines. And of course, we bring you nothing but the best in this webinar. We're going to have someone you have listened to before, and he is a very important part of the pandemic response in the Philippines, epidemiologist and senior technical advisor of EpiMetrics. It's my pleasure and honor to introduce Dr. John Wong. John, please go ahead with your presentation.
Thank you, Susie. Thank you for having me. I'll just share my slides.
Go ahead.
Do you see my slides?
Yep, it's now in PowerPoint. Go ahead, John. Go ahead.
Okay, thank you. So I'd just like to talk about Delta and how it's related to vaccination. Let me start with some key messages. So the Delta variant is a game changer in terms of what we know about the virus and the previous and current control measures we have. We have found have been less effective against Delta. Because of this, the goal that we initially have of herd immunity may be out of reach. I'll explain more of this about this later. So we need a change in paradigm from wanting to eradicate the virus through vaccination to prevention of severe disease and death, which is also not a bad outcome. But in order to get to this, the vaccination program needs to prioritize the elderly who are more likely to die, but also to improve the supply chain. So this has been the trajectory of the original variant, the original strain. It's this part now, and the different variants that have been introduced into the country. So alpha, beta, delta. This graph stops at mid-May. At that time, delta was about 11%. Now, beginning of September, we're at about 70%. So in 3.5 months, it has grown about 6 times. So this is we can see the high transmissibility of Delta from our experience. So although we have not been sampling or sequencing sufficiently enough to get a complete picture of the presence of Delta and other variants in our country, we can see from the behavior of our epidemic curves at both the national and the NCR level. This could possibly be the effect of Delta. So it has exceeded the previous 2 surges we had at both levels. In terms of death, we also see the rapid increase in deaths. There's a little delay, about a month, pero we're seeing again an increase at the national level, also an increase at the NCR level, but less steep. So why do we say that herd immunity may be out of reach? For several reasons. First, all the vaccines are good in preventing severe disease. They have, even in the clinical trials, we didn't know whether or not they would be able to block transmission. And with more experience, more trials, since it's the rollout, we know that they may not be transmission blocking. So in one study in Massachusetts, there was a public celebration. From that public celebration, well, in Massachusetts, they were about 69% vaccinated. So they found 470 cases that emerged from that public celebration. Of this 469, about 74% were vaccinated, and of those, about 79% were symptomatic. But fortunately, none of them had severe disease, or very few of them had severe disease. No, so from this, they concluded that the vaccines may not be good, no, at blocking transmission. Second, we saw that the alpha variant was more transmissible, no, about 57%. The beta variant was resistant to vaccines, and the delta variant is both. No, it's more transmissible but also more resistant to vaccines. Third, no, the vaccine rollout in our country has been very uneven. No? So it's uneven in both person and place. No, in terms of person, for the country as a whole, we're about 13% vaccinated. No, but among the poor subpopulation, only about 4% are vaccinated. In terms of vaccine hesitancy, for people who have at least a high school education, no, only about 13% no, say that they don't want the vaccine. But among those with less than a high school education, about 37% do not want to be vaccinated. Again, no, in terms of place, no, it's 13% at the national level, but NCR is very highly vaccinated. Now we're at I think 46 or 47% now. No? But BARM, no, in Mindanao is only about 7% vaccinated. No? So it's very uneven. No? And you cannot talk about herd immunity, no, when you have this unevenness, no, in terms of vaccination. Fourth, no, there is some evidence that there's waning vaccine immunity among the elderly and people with comorbidities. No, there's no evidence yet. No, there's insufficient evidence yet to say that we need booster doses for the general population, but at least for the elderly and people with comorbidities, no, because of their depressed immune response, they will need booster doses. No, and lastly, people's behavior will change, you know, after vaccination. Remember that the clinical trials for vaccines were done when people were taking precautions. No, they were under quarantine, they were masking, they were social distancing. So it was vaccine plus a lot of other protective measures. No, but we have seen from many countries that after people have been vaccinated, no, they start going out, they start not wearing their masks, no, failing to socially distance, no, having large gatherings indoors, no, traveling, no, and this extra risky behavior, no, will lead to more breakthrough infections also. So let's talk about how herd immunity or the herd immunity threshold, no, is computed. No, why do we say that we need to vaccinate 70% of the population? No, it's from this formula. No, it's actually quite a simple formula. No, 1 minus 1 over R naught. No, so R naught is the ability of the virus to transmit. No, so the higher the R naught, the more people can be infected, no, from a single index case. But we have to divide this by vaccine efficacy. No, so what does that mean? No, the more transmissible the virus, the more people we have to vaccinate. No, the higher the herd immunity. No, so which is logical. No, but the lower our vaccine efficacy, the higher also, no, is our herd immunity threshold. Because we don't have a perfect vaccine. No, all vaccines are less than 100%. No, so if a vaccine has an efficacy of 90%, no, if we vaccinate 100 people, only 90 of them will actually be immune. No, so that means we have to vaccinate more, no, just to achieve the target. So with the original strain, no, the R naught was about 3. No, this was the R naught in Wuhan. No, with the perfect vaccine, the herd immunity threshold is 67%. No? So that's why most countries say they want to achieve 70% vaccination. That's also our national target. No? But looking at the whole portfolio of the vaccines we're using here in the Philippines now, plus the number of doses that have been administered now, our weighted vaccine effectiveness is about 72%. So which brings us to a herd immunity threshold of 93%. No? So it's higher. No? It's almost 100%. No? But then if you introduce another variable, no, of variants that are more transmissible, no, alpha and delta, it brings it up to 100%. No? So now you have to vaccinate everyone. No? That means herd immunity is no longer possible, no? Kasi you're vaccinating everyone. So it's in this context, no, that we say that herd immunity is no longer possible, and we need to focus on preventing severe disease and death instead. No. But here's the good news. No. Although vaccines are not good in blocking transmission, no, and there are breakthrough infections, no, it's still pretty good, no, in preventing severe diseases and death. No. This is data from Israel. No. Red is the vaccinated, green is blue is the vaccinated. No. When the Delta variant arrived, no, the number of severe cases among the unvaccinated took off, no, and it's still going up. No. But among the vaccinated, no, there was a slight increase, no, but the gap is actually widening, no, between the vaccinated and unvaccinated. No. The vaccinated are continuing to be protected. So because we see the protective effect of the vaccines, no, let's ask the question, no, who will benefit the most, no, from this protective effect? No? If we look at data from the Philippines, no, blue is our infection rate. No? Last year, not many children, no, were infected. Most of them were adults, no, more among 20 to 30 years old, no, because they're out more often. No? The elderly are still exposed, no, even if they're at home, no, because probably people who are working in their households, no, bring the infection back. No? But look at mortality. No, the red bars are mortality. No, even if more of these people are infected, not a lot of them die. No, deaths only start to go up around 45 years old, 50 years old. No, and it continues going up. No, so they have about the same number of risk of infection, but several times, no, the risk of death. So, which brings us to this insight. No, if we prioritize vaccinating the elderly, no, we can actually prevent most of the deaths. No, so if we apply the Pareto principle, no, now what is the vital few people that we need to protect in order to prevent most of the deaths? No, taking NCR as an example, no, people who are more than 50 years old in NCR represent only 17% of the population, yet they represent 80% of the deaths. No? So if you're able to vaccinate all of these people, no, you can prevent 80% of the deaths, no, and reduce or avoid, no, the collapse of the health system. No? So where are we now? No? For A2, the elderly, we're at 48%. No? Considering that we're on the 7th month, no, of a 10-month plan, no, to vaccinate, no, 70%. No? We need to do better here. No? For A3, persons with comorbidities, we're at 36%. No? My is lower than the estimate of DOH, no, kasi there are more persons with comorbidities, no, than people who have, than those who have registered. About 8 million have registered to say that they have comorbidities, no, but about 14 million actually have comorbidities. No, a lot of people don't know, no, that they have chronic illnesses. So what is a possible strategy, no, or a good strategy in terms of getting people vaccinated? No? So if you look at this bar graph, no, and this is the entire Philippine population, about 13% are already vaccinated. No? This is the blue segment. No? From the SWS survey, we know that about 42% are willing to be vaccinated, are already willing, but not yet vaccinated. About 21% are undecided, they may or may not, and about 24% are unwilling. So when you segment the population this way, there are different ways of approaching them. These people are already willing. You don't need to provide health communication or promotion anymore. You just increase access. Have a supply of vaccine for them. These people can still be convinced. They're undecided. So this is where vaccine education comes in. And this segment, unwilling, later on you can apply soft mandates, like requiring them to mask or to have regular testing when they go back to work. But this is a problem that we can postpone for later. It's not needed now, because we're only at this point in terms of vaccination. We have a long way to go to get these people vaccinated before we even have to deal with these people. So let's look at access. Where are the bottlenecks in access? So if you look at coverage, there are two types of coverage: potential coverage, what we can possibly deliver, and actual coverage, what we're actually delivering. Potential coverage has three components. Make sure the supply is available. Second, make sure there's somewhere people can go to get that supply, to get the vaccines. So these two are supply components. Third, make sure that people want your service or want your product, or want to be vaccinated. So this is part of demand. And then finally, that these people who want to be vaccinated come for at least one dose, your first contact with them, and make sure that they effectively complete the dosage, so that they can have sufficient protection. So, for example, studies show that even for the mRNA vaccines, one dose is not enough. You need 2 doses to be protected. So that gives you quality service. So if you look at where we are now, so this is a bottleneck analysis. It tells us where the bottlenecks are in our program for covering everyone for the vaccine. So this is if we want a target of vaccinating 100% of the population, and this is if we have a target of vaccinating just 70%. But even if you try to vaccinate 70%, you already have to start thinking about vaccinating children 15 years old and above, because they represent the older 70% of the population. So if you want to vaccinate 70%, you have to vaccinate as low as 15 years old. So where are the bottlenecks? If we look at supply, we're actually doing best here in terms of accessibility. So 68% of the population say that they have access to a vaccination site. So the LGUs have been doing a good job locating their vaccination sites. Of course, there's still the 32% who have no access to the vaccination site. So that we can and should still improve on. If you look at availability, do we have enough doses? Right now, in country, meaning delivered inside the country, we have enough for 26%. So this is one of the bottlenecks. It's a supply bottleneck. In terms of accessibility, we've gone a long way. Back in, I think, December, when SWS did its first survey, the acceptability was only 1/3. So we moved the needle past 50%. So there's still 45% to go, and some of these are undecided and convinced. But we're doing better here, although it's also a bottleneck. Third, we have 55% who want to, or for about 45%, kasi 12% have been vaccinated. About 45% who want to be vaccinated, but only 30% have actually gotten a first dose. So we have a long way to go to getting the other, the balance to to come and get their first doses. And of the 30% who have gotten their first dose now, only 12% have actually gotten full dose or complete doses, or are effectively covered or protected. No? So this graph now just shows us where the bottlenecks are in terms of our vaccination coverage. No? So aside from focusing on the elderly and vaccinating them at a faster pace, now we also have to make sure that we have more supply. But given our current situation where we don't have enough supply because there's also worldwide, the best thing is to prioritize, no? And prioritize A2 and A3. So this just shows the area of unmet need. No? And these are the gaps, no, that we have to fill. Okay, so in conclusion, no, maybe it's not so bad that herd immunity is not out of reach. No, eventually a lot of scientists are saying that eventually COVID will be something like influenza. No, it will be endemic. It will always be there, but because of vaccination, we won't have the high levels of hospitalization that we have now. No, just a much smaller percentage of people will be hospitalized now, but everybody else now who are vaccinated can carry on their daily lives. No, we don't have to quarantine. No, there will be no need for lockdowns. No, our children will be able to go back to school. Maybe it might still be a good idea to wear masks now when you're sick. No, but we can live with fewer controls. No, and also live safely, without hospitalizations and deaths. Thank you.
Thank you so much, Dr. Wong. Really interesting to have that perspective, at least for the Philippines, because a lot of folks have been asking, so short of a comparison or a vis-a-vis of the Delta variant and the rising number of cases, as well as our vaccination coverage in the Philippines. So thank you for putting that into perspective, Dr. Wong. I'll turn the floor over to Dr. Susie before we call on our audience for the Q&A session.
Okay, so thank you very much. Thank you, John, for that excellent presentation. Also, I think our audience, as you can see in the chat box, is really appreciating all the figures that you've been able to put together for this webinar. And I know you listen to John on TV and radio, but sometimes you cannot capture everything on the soundbite. And it's really great to have John with a more in-depth, sort of an in-depth analysis of what is happening. So thank you so much. I'm going to ask our panelists to now all open their cameras. We're going to have a panel discussion, but before that, we have a public service announcement from TVUP. Go ahead, please.
Birthday, Mahal!
Thank you, Mahal!
Happy birthday,
Happy
Mommy!
birthday,
Hi,
Mommy!
Dad! Hi, Mom!
Happy birthday!
Thank you, mga anak! Thank you!
Love you, Mommy!
Miss na namin kayo!
I miss you, both of you. I miss you.
Miss ko na kayong lahat.
Mommy, sana magkakasama na tayo muli.
Miss na namin, Mommy. Happy birthday, Mommy.
Miss and love you, Mommy.
What did you wish for, Lola?
My wish? Magpapabakuna na ako.
Ako din.
Dahil mahal ko kayo, magpapabakuna ako.
Okay,
Thank you
very
much.
nice.
Yeah,
Yes,
Raymond, talk about it a little bit. Yeah.
Yep, the COVID communication public service announcement is one of the many outputs of the UP research entitled Communicating COVID-19 in Post-Quarantine Philippines. It's headed by our Vice President for Public Affairs, Dr. Elena Pernia, and funded by the DOST PCHRD and the DOH as part of the AHEAD HSPR project. Over to you, Dr. Susie.
Yeah, I think, Raymond, it's really consistent with what John was saying. No? If only 48% of our seniors are vaccinated, we really have to continue to push this. And it's great to have these ads. I think our audience is also enjoying them. To remind us that we all have a responsibility to have our seniors vaccinated because they could really benefit from this a lot. So thank you very much to all our speakers for the excellent presentations. And we're going to take in a couple of questions from the audience, but I just wanted to get the ball rolling on one aspect of, I think all of you touched on this. And I think Franco started on this when he was saying that there is a decoupling between the number of cases and the number of deaths. So Franco, can you talk a little bit more about that? Because it seems to me that if we are expecting that, play the tape to the end, if we're looking at what happens after this, it's that this becomes a endemic disease. We always have it, right? But you can get vaccinated for it. And if you're vaccinated, you won't die from it. And our hospitals become better at treating it. So should we be, the disconnect is that we are constantly reporting the number of cases. So people see the numbers and they think about that rather than see and think about, is this killing people? Is it bringing them to the hospital? So I'm going to ask Franco to start with that because you introduced the concept of decoupling, which I think our frontliners would like to know more about. Franco, please go ahead.
Yeah, first of all, the cases are probably very underreported. So, for example, United States testing capacity is 10 times higher than the Philippines per capita. And we're actually still underestimating our cases 4 times. So probably at least 30% of the population is already infected. So if you think about it, your case is probably 10 times more than your reported cases. So the most important data is death, but you can always, you can also underestimate deaths. For example, in India, they said, 5 to 10, the underestimation of deaths is 5 to 10 times. But anyway, decoupling is when you're able, Dr. John Wong just, mentioned that 80% of the deaths in the Philippines are in individuals 50 years and 50 years and older. So if you can vaccinate all of them, then you can decrease the overall death rate. So that's really just that's if you vaccinated everyone at the same rate, then you won't have a decoupling. You will have the same, the increase in cases will be proportional to the increase in deaths. So, but if you vaccinated the individuals with the highest risk of death, then of course you're going to be, the cases may increase, but the deaths should stabilize. Yeah.
So we really need to focus on those who are most vulnerable, older persons. John, would you like to say something more about that?
Yeah. So Dr. Franco has talked about decoupling. No? A while ago, I showed the epidemic curves of NCR and the national level, and also the death curves. No? The rise in deaths in NCR is as steep as that for the national level, and I suspect it's because at the national level, 48% of the elderly are vaccinated, but in NCR, 76% are vaccinated. So that might already be having an effect, in preventing a lot of the deaths that are happening at the national level.
Okay. Raymond, I think we have questions from our audience. Go ahead, please.
So we have 2 from our audience. They have already put in their questions, but we wanted to have them ask their questions live. So please welcome to the webinar, Maria Jane Villanueva. Jane, could you open your camera and yeah, there we go. And
Good afternoon.
go ahead po, ma'am.
My question is regarding the state of pandemic. Now, it seems that this COVID pandemic won't end because one of the characteristics of the virus keeps on mutating and adjusting to its environment, like the latest variant on Mu, where it is said that it's resistant to all vaccines. So in this case, how could we live our life with it when in the most safest way that we are not limited to perform our daily activities of living? If this virus keeps on mutating, it would also be difficult to develop a specific vaccine to keep us protected. So what could we do to be protected and to be safe?
Okay, would anyone want to take a stab at that question?
Yeah, I can
Oh,
answer.
Franco,
So,
go ahead.
yeah, first of all, the mutation rate of COVID is still at least 2 times slower than influenza. So if this is influenza, all the vaccines will be useless in less than a year, right? That's why we have vaccinate every year for influenza. So it's still slower than influenza. So that's a good thing. Second is our vaccines are still better than influenza. So I'll give you an example. So in a normal year, the efficacy against protection against infection for influenza is 20 to 60%. Only 20 to 60%. But influenza vaccines, the protection against severe disease can be up to 80%. Up to 80%. The vaccines we have right now for COVID is at least 80%. Sinovac, in Chile, Sinovac was 85%, at least for severe. For Brazil, there was a study just came out. It's about 75%. For AZ, it's about 90%. So we still have a better vaccine, and COVID is still slower in terms of mutation rate. So yeah, I mean, we probably will not achieve herd immunity, but with influenza, we haven't achieved herd immunity with influenza, and we're doing fine with influenza, right? We just need a good vaccine every year. But with COVID, we probably will need a few boosters here and there, and hopefully it will be endemic like influenza, in which we can control it. Yeah, it's not gonna be like a disaster forever.
Yeah, but somehow thinking that it can mutate, it's something scary for the general public, because it seems that the vaccines will not really protect us for quite time, because it is said that the vaccination can only protect us for 90 days. So
well, I've given you the data. The protection against infection is not that high, but the protection against severe disease, hospitalization, death, is more important. So most of the breakthrough infections if you're vaccinated and you get a breakthrough infection, is asymptomatic or mild infections, sneezing. So if you have a breakthrough infection, for example, after vaccination, the most common symptom will be sneezing and runny nose. It should be fine, right?
Oh, yeah. Thank you very much. Thank you very much, Franco. Yeah, John, please go ahead.
Let me just correct that. No, effectiveness of vaccine is more than 90 days. No, and a lot of people have been looking at antibody levels as a measure of immunity. No, but antibodies are just one component of our immune response. No, and it's really expected for antibodies levels to wane, after vaccination, because otherwise our blood will be so full of antibodies against different types of infections. It will be so clogged. The other part of the immune system are found in the bone marrow. So there have been studies of people who have been vaccinated or have developed natural infection. They found that in the bone marrow, there are memory T and B cells that are ready to produce antibodies when the infection is reintroduced. So immunity to COVID, after vaccination lasts longer, than the presence of antibodies.
Thank you very much, John. Thank you very much also, Jane, for participating in the webinar. Raymond, do you have another person who is going to ask a question?
Yes, one more question, and this one coming in from Anthony Val Gotanco. We'd like to have our representatives from Taiwan and Thailand to chime in. Val or Anthony, are you? There we go. Okay, Sir Anthony, please go ahead with your question, and we'll direct it to
Hello,
Roy and
everyone. Good
Dr. Lin.
Hi, good afternoon, everyone. Roy and Dr. Lin. I'm Gary, and I'm a chemical engineer here in Las Piñas. My question has three parts. Firstly, basically, it's about the booster shots, because we've been reading that the vaccine, it's not quite sure yet if it will last for about a year, the protection. So my first question is the booster the same form, or is it identical to the ones that we got during our first and second shots? And I ask this because I know that among the vaccines, at least one doesn't have the same form for the first and second shot, and that's Sputnik. So do all of the other shots have the same booster as for the first and second shots?
I can answer. The Sputnik, the mRNA, the spike protein DNA for Sputnik is the same. It's the adenovirus delivery that's different. So the other one is A5, the other one is A26. So it's just different adenovirus delivery, but it's the same DNA. Now for Moderna and Pfizer, they can actually make an mRNA specific for example, for Delta, but they haven't done it yet because the original vaccine, with their studies, they've shown that the increase in neutralizing antibodies at least 10 times, even with the same original virus. But they can actually change it to very specific to another variant.
Okay. You said you had another question?
Yes. The second part of the question is, Doctor, about how many months should the booster be given, considering that I think the US recommends 8 months after the full vaccination. But I read somewhere in CNN a few days ago that for Sinovac in Thailand, specifically, they said it should be, I think, something like 6 months.
Okay, anyone wants to? Maybe Franco, that's still you, right?
I can, yeah, it's quite controversial. I mean, the booster is to increase the protection against infections. We don't have any data so far that there's a decrease, there's a waning in immunity against severe infection. So that's now for immunocompromised patients, that's different. We don't even call it a booster. So for example, in a New England Journal article, it's a randomized trial, for patients with solid organ transplants, only 18% will have immunity, 18%. And if you give the third dose, it will increase to 50%. So, that's not even boosting, it's like having a second primary vaccination. So that's different. So for me, I would agree with boosting immunocompromised patients, but for the general population, that's quite controversial. But they have done studies. For example, for CoronaVac, there was a study, a phase 2 placebo-controlled trial in China, showing that the neutralizing antibody is increased 3 to 5 times higher if you give it 6 months after. So they had 4 schedules: 0, 2 weeks, and then 6 months after 2 weeks. Then they have 0, 2 weeks, and 4 weeks. Then the other one is 0, 4 weeks, and 6 months, and so on. And they've shown that if it's longer, 6 months after the second dose, the neutralizing antibodies increase 3 to 5 times higher. So at least they have data there. The question is, would it actually decrease transmission or decrease severe disease? Yeah, certainly it would probably decrease infections.
Okay, thank you very much, Franco.
Doctor, one last question, Doc.
Okay, is that a quick one? A quick one, please. Yes.
It's a quick one. Yeah, because I had my Sinovac shots in May, and then we were hoping to travel sometime next year, and we know that Sinovac is not recognized in other countries. So is it possible for us to, like, let's say, shift from Sinovac to another recognized vaccine when we have our booster or a new shot?
Okay, that's probably for Franco again or John.
I'm not sure about it's emergency use yet. So if it's fully approved, you can do whatever you want with the vaccine. But there's studies on we call it heterologous vaccination, where you can mix and match vaccines. The most common though is Pfizer and then AstraZeneca, or AstraZeneca and Pfizer. I'm not sure about, we don't have any data yet, I think, for Sinovac and other vaccines, but theoretically it should not be harmful if it's 6 months after, theoretically.
Yeah. Okay, thank you very much, Franco. And unfortunately, it is close to the top of the hour, and we'd like to go on talking about this, but we can't. It's an international virtual meeting, and we would like to stick to the time as much as possible because our speakers are coming from different time zones. And we are going to, are we going to do an evaluation, Raymond? No?
Yes, we could do that. TVUP, do we have that?
So while we're doing an evaluation, I would like the speakers to just reflect on this question for your parting words. So from the experiences of where you are right now, what do you think is an important message or lesson or a good practice that we can use in the Philippines? So just a brief, your brief parting words would be about something that you see being done where you are right now that could help us here in the Philippines. Okay, so Raymond, please go ahead with your evaluation.
Thank you, Dr. Susie. So as we are giving a very, very short break to all of our speakers just to allow them to compose that final message that they will be parting later on to our audience, we have 5 questions here that represent our assessment questions. So for those who are asking if we have an evaluation survey monkey or some other poll, this is it. So please, for those who are in the Zoom webinar at the very least, about 1,660 plus, please input your answers. We'll be very, very much appreciative of all of your inputs here. I'll read off the questions. The panelists demonstrated thorough knowledge of the topic. The panelists were well prepared and organized. Panelists spoke clearly and audibly. Panelists used appropriate language with technical medical jargons explained. And finally, the topic contributed to new perspectives and knowledge on managing various key COVID-19 health issues through our expert lineup of speakers. We will not be closing the poll, even though we will be shifting to the final messages. Please continue to key in your answers as we move on to the next part. Dr. Susie?
Okay, thank you very much. So parting words first from Dr. John Wong.
Susie, am I supposed to answer the same question from the Philippines?
How about John? How about something that you heard from the speakers?
I think I was struck most by what Dr. Chun-Yu Lin said, no, that Taiwanese are very disciplined, no? And part of our shortcomings over the past year was in terms of observance of the non-pharmaceutical interventions, no? Maybe if we had more masking or social distancing, or even the health-seeking behavior of when we're symptomatic, going for a test, no? Or going for a consultation, no? we could have avoid a lot of cases at the start of the pandemic. Thank you.
Thank you, John. We'll now go to the parting words of Dr. Chun-Yu Lin.
Yes, can you hear me?
Yes, go
Yes,
ahead.
loud and clear.
Okay. Thank you very much for this very kind and excellent webinar, and for inviting me to join with you. Very briefly, I can provide some more information. Now in Taiwan, we are still encourage our people to get the vaccination, no matter they were single one or mixed with the other brand name, the other type, because we think it's good. And as we know, the vaccination could reduce the transmission period of the virus, even if you were infected. And the mutation of virus will happen during the replication. So if we can lower down the susceptible cases number, then we can prevent for the next mutation and the next pandemic in Taiwan. So nowadays we do it. And also we prepare for the pharmaceutical, I mean the antiviral medicine. If it's available, we will prepare for that to lower down our mortality rate. So as you know, the pandemic will affect the economic a lot. So we have to do it as soon as possible to avoid the big economic problem in Taiwan. Thank you.
Thank you very much, Dr. Chun-Yu Lin from Taiwan. We're now going to call on Roy Wadia from Thailand. Roy?
Yeah, I would just say, at the risk of sounding simplistic, that don't underestimate the power of communications to continue to contribute to either the way that health can handle the outbreaks or worsen it. And we've seen examples from all over the world, not just in Thailand, of mixed messaging, inconsistent communications protocols. So really, we need to get our act together when it comes to communicating, because we're into the long haul and we know that there is an infodemic out there. I think the key thing that hasn't really been done well so far is to involve communities and people themselves in communications about their own health. Find a way to have that dialogue and that two-way interactivity in a strategic and focused way, yes, but it has to be done rather than having top-down edicts may or may not always be consistent. No easy answer for this, but I think this is one of the aspects of the pandemic that has really contributed to it worsening and people not getting vaccinated and not taking the precautions that they should be. Thank you.
Thank you very much. That was Roy Wadia. And now we're going to Dr. Franco Felizarta. Franco, please go ahead.
So, so just remember, the vaccine still has good protection against severe disease. And, at least half of these breakthrough hospitalizations will be in immunocompromised patients. And if the breakthrough infections will not be uncommon, I actually expect some a significant number of breakthrough infections, but most of them will be asymptomatic or mild. But remember, if you have a breakthrough infection after vaccination, you can still transmit it to a high-risk person or a person who is immunocompromised. So it's very important that even if you're vaccinated, you have to wear your mask, especially in crowded situations or indoors that are not well ventilated. So.
Thank you very much, Dr. Franco Felizarta. So on behalf of the organizers of Stop COVID Deaths, we'd like to thank all our panelists for the excellent, brilliant presentations. And for our audience, you can watch them again on YouTube. I think it's been very clear that this Delta variant is sweeping not just the Philippines. And so all of the challenges that we're encountering right now are not unique to us. Other countries are also having their own challenges, their own problems, but the messaging is still clear. that vaccines are effective in preventing severe infection or death. And so therefore, it's incumbent upon all of us, especially our frontliners, to get people vaccinated, to continue to practice social distancing and wear masks, and ensure that there's hand hygiene, and not to engage in the infodemic. We try our best to bring you the best speakers, and you can see how hard they prepare for us all to understand and learn what is happening, for us to get up-to-date information. And as we can see, everywhere it's challenging. The US, Japan, Taiwan, Thailand, it's a challenge. But we don't want you to lose hope. We want you to know that we are all working on this together, and across the seas, our colleagues are here with us. Nakikisa sila sa atin na gustong magbigay ng impormasyon para makatulong din kung anong umaandar sa kanila, baka makatulong din sa atin. So I hope that this webinar has been very, what should I say, educational for all of you. Certainly for me, I learned so much. And again, I'd like to thank all of our speakers for their time and their effort for being with us on the webinar. So next week, don't forget to join us. We have a very interesting topic. Our topic is limited face-to-face. So this is now talking about school, limited face-to-face school. Ligtas ba? No, so alam ko marami sa inyo may mga anak kayo, o kaya meron kayong mga kamag-anak na babalik na sa eskwela, no? Ligtas ba to? Dapat bang payagan natin? Ano bang gagawin nila? So we are going to talk about how safe is it to return to school. The context is the Philippines, and we have some excellent speakers for you. So don't forget to be with us next week as we discuss limited face-to-face, ligtas ba? Raymond, go ahead.
Thank you, Dr. Susie, and thank you again to our excellent lineup of speakers for that rich exchange of ideas. Marami din po kaming natutunan, at sana po ang lahat po na nag-attend at nag-view ng ating webinar also has that same level of understanding now, better understanding now that we have learned so much from our speakers. And although it's something of a challenge, not just in the Philippines but globally, we hope that all the learnings and all the best practices shared by our experts including communications, mental health, preparations for the pandemic, etc., and a better appreciation of the value and significance of vaccination will be so much more inculcated in each and every one of us. We are seeing po on the screen our assessment poll results. I think that it's a little bit on the high side ang number of respondents po natin. We have 1,286 respondents, Dr. Susie, and 92% of them, or at least average of 90% of them, are saying that they strongly agree with each and every item listed here in the assessment poll. Okay, so but before we draw to a close or conclude our program, we'd like to acknowledge each and every one of the different members comprising the Stop COVID Deaths webinar series team. Maraming salamat po sa inyong lahat. But most importantly, hindi po ito magagampanan at hindi po ito magiging matagumpay without our viewers. Let me just greet them all the way from Western Pangasinan District Hospital in Alaminos, Ifugao State University Eye Center in Ifugao, Manila International Airport in Pasay, Masbate Provincial Hospital, the Philippine Health Insurance Corporation located in Iloilo City, and internationally, obviously, we have Professor Atsuro Tsutsumi and also his colleagues from Kanazawa University in Japan, the National Center for Global Health and Medicine in Tokyo, Chun-Yu Lin Hospital in Taipei, Taiwan, Kanto Hematology and Blood Transfusion Hospital in Kanto, Vietnam, Phnom Penh in Cambodia, Thawi, Watana, Bangkok, Thailand, from Penang, Malaysia, Betaya, India, Sharjah, UAE, and Dubai, also in Dubai, King Abdulaziz Medical City in Riyadh, Oman College of Health Sciences in Muscat, Lunichi Ali University of Blida 2, Algeria, University of Fiji, Lautoka, Whitby in Ontario, Canada, and Sasil in Italy. So maraming salamat po, and really each and every one of you represent our success for this Stop COVID-19 webinar series. And for those who are asking, yes, we do archive and you'll be able to watch them on the playback if you go to www.youtube.com, look up the TVUP channel, and you'll be able to see all our previous 67 and then pagkatapos po nito 68 episodes there. So maraming salamat po. And this formally closes our webinar for this week. We look forward to your company again next week, our regular Friday lunch date from 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others love before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, I'm pushing on despite the tears. Please take us through another day. Just hold my hand, and I will hold the line. I will